Welcome back to the deep dive. Today we are stepping into the ER bay to tackle a category of medicine that I like to think of as the great masqueraders. We're talking about conditions that, walk in looking like sepsis, looking like heart failure, or even a psychiatric break, but are actually biochemical ticking time bombs. We're digging into endocrine emergencies.
It's a fantastic topic. The endocrine system is usually the body's background operating system. It's slow, it's regulatory. But when it snaps, it doesn't just glitch, it crashes the whole hard drive.
And we are basing this discussion on the comprehensive text Endocrine Emergencies by Alexander L. Schifrin and his team. This book is, it's essentially the survival guide for when the body's hormonal check engine lights turn into a full-blown engine fire.
That's a great analogy, because the mortality rate for these conditions, things like thyroid storm or adrenal crisis, it's shockingly high if you miss that first window. Schifrin's text really emphasizes that these patients often die because the clinician treated the symptom, the fever or the low blood pressure, but missed the invisible chemical storm causing it.
So our mission today is to decode that storm. We aren't just listing symptoms. We want to understand the pathophysiology, the why behind the crash. We're going to map out the body's 4 critical control centers: the thyroid, the adrenals, the pancreas, and the pituitary.
Let's start at the neck, the thyroid.
Right. We usually think of thyroid issues as long-term management, weight gain, fatigue, that kind of thing. But Schifrin describes 2 acute extremes, the fire and the ice. Let's start with the fire. Thyroid storm.
Or severe thyrotoxicosis. This is a state of total metabolic decompensation. It's not just too much thyroid hormone, it's the body losing its ability to regulate heat and heart rate entirely. And usually this happens in a patient with underlying Graves' disease who gets hit with a trigger, an infection, trauma, surgery, or simply stopping their meds.
And clinically, this looks terrifying. You're seeing hyperpyrexia fevers often spiking over 104 degrees Fahrenheit. That's 40 Celsius. But the key discriminator here isn't just the fever, is it? It's the heart rate.
Exactly. You see tachycardia that is totally out of proportion to the fever. If a patient has a fever of, say, 102, you expect a certain heart rate. In a storm, they are running at 140, 160 beats per minute. And then there's the CNS dysfunction. The brain is effectively cooking. They go from agitated to delirious to comatose.
The text highlights the Birch-Wartowski point scale here. It's a reminder that this is a clinical diagnosis. You don't wait for the TSH lab result to come back before you act.
You can't. Time is tissue. If that score is high, you treat. And the treatment protocol in the book is a masterclass in pharmacology because the order of the medications is non-negotiable.
Okay, let's walk through that 5-step sequence. Step 1 is supportive care, cooling blankets, fluids, ICU admission. But there is a huge contraindication here for fever reduction. We absolutely cannot use aspirin.
Right. It's a classic board question and a life-saving pearl. Salicylates, like aspirin, displays T4 and T3 from the proteins that carry them in the blood.
So if you give aspirin, you're knocking more active hormone loose?
And dumping it right into the circulation.
Yeah.
Precisely. You are pouring gasoline on the fire you're trying to put out. You stick to acetaminophen for the fever.
Okay. Step 2 is beta blockade. The drug of choice is propranolol. But it's not just because it slows the heart, is it?
No, propranolol is unique. It's a non-selective beta blocker, so it handles the heart rate. But at high doses, it also blocks the peripheral conversion of T4 to T3. And since T3 is the active hormone doing most of the damage, propranolol hits the storm from 2 angles.
Okay, so then step 3. We stop the production factory. We use antithyroid drugs like propylthiouracil PTU or methimazole.
Correct. These block the synthesis of new hormone.
Now, step 4 is where the physiology gets really interesting to me. Iodine. This is the iodine trap.
It is. It's counterintuitive. We know the thyroid uses iodine to make hormone, so why give it? Because a massive load of iodine shuts down the release of preformed hormone. It basically locks the doors of the gland. This is called the Wolff-Chaikoff effect.
But timing is everything here. Schifrin is very specific. You must give the antithyroid drugs, the PTU or methimazole, at least 1 hour before the iodine.
Yes. If you give the iodine first, before you've blocked synthesis, the gland will just use that iodine to manufacture a massive amount of new hormone, the Jod-Basedow phenomenon. You have to shut down the factory line before you lock the warehouse doors.
And finally, step 5, glucocorticoids. Steroids like dexamethasone.
Which again, serves a dual purpose. It blocks that T4 to T3 conversion, further cooling the metabolic engine, and it covers you for potential adrenal insufficiency, which we'll get to.
So that's the fire. So now let's look at the ice. Myxedema, coma.
This is the other side of the coin. Severe decompensated hypothyroidism. Everything slows to a halt. The classic patient is an elderly woman, winter months, often with a history of thyroid surgery or neck radiation. She presents with altered mental status and profound hypothermia.
We're talking body temperatures below 95 degrees Fahrenheit, 35 Celsius, and unlike the storm, they aren't breathing fast, they're hypoventilating.
Which leads to CO2 retention and narcosis, contributing to the coma. And physically, they have this non-pitting edema myxedema. It's due to the deposition of mucopolysaccharides in the dermis. They look puffy, their face is swollen, their tongue might even be enlarged.
The treatment seems obvious. Replace the missing hormone, give them IV levothyroxine T4, but the book screams about a golden rule here involving steroids.
This is absolutely critical. Before you give T4, you must give stress dose hydrocortisone.
And this ties back to Schmidt's syndrome, right? Autoimmune polyglandular syndrome.
Exactly. Patients with autoimmune thyroid disease often have coexisting autoimmune adrenal failure. If they have adrenal insufficiency, they are barely hanging on with what little cortisol they have.
So if you just dump T4 into their system,
You stomp on the gas pedal. You dramatically increase the metabolic rate and the body's demand for cortisol. But if the adrenals are empty, the engine revs, the fuel pump fails, and the patient goes into immediate adrenal crisis and dies. You have to prime the pump with steroids before you hit the gas with thyroid hormone.
that transition brings us perfectly to the next system. Let's move down to the adrenal glands. We just mentioned adrenal crisis, but let's start with the pressure cooker tumor, pheochromocytoma.
A rare catecholamine-secreting tumor. It floods the body with adrenaline and noradrenaline.
The presentation is usually dramatic. It's not just high blood pressure, it's a hypertensive emergency.
Right, you see the classic triad: headache, sweating, and palpitations. But the blood pressure can be 220 over 120 or higher. These patients often feel a sense of impending doom.
And just like with the thyroid, pharmacology is a minefield here. There is a rigid rule, alpha before beta.
You must blockade the alpha receptors first. We use drugs like phenoxybenzamine or phentolamine. Alpha receptors are what cause the blood vessels to clamp down. You have to force those vessels to relax and open up first.
And if a clinician sees that high heart rate and instinctively reaches for a beta blocker like metoprolol first, what happens?
It's a disaster. Beta receptors on blood vessels actually provide a little bit of dilation. If you block those beta receptors, you leave the alpha receptors unopposed. The catecholamines have nowhere else to go but the alpha receptors. The vessels clamp down even harder.
So the blood pressure, which was already sky high, just skyrockets.
You can precipitate a stroke or acute heart failure instantly. Unopposed alpha stimulation is a lethal error. You must open the pipes before you slow the pump.
Okay, now let's talk about when the adrenals fail completely. Acute adrenal insufficiency or adrenal crisis.
This is a state of profound shock. The hallmark is hypotension, low blood pressure. That is refractory to fluids and vasopressors. You are pouring in fluids, you've got them on norepinephrine, and the pressure just won't come up.
Because cortisol is required for our blood vessels to actually respond to catecholamines. Without cortisol, the vessels are flaccid.
Correct. And chemically, you are looking for a specific pattern. Hyponatremia, so low sodium, and hyperkalemia, high potassium.
This is the mineralocorticoid effect, or the lack of it.
Right. Aldosterone usually tells the kidney to save sodium and dump potassium. Without it, you waste salt and hold on to potassium. This, combined with hypoglycemia and shock, creates a very specific clinical picture.
And the causes vary. Abruptly stopping long-term steroids is the most common. But Schifrin's book details a particularly gruesome cause, Waterhouse-Friderichsen syndrome.
Yeah, this is adrenal hemorrhage in the setting of severe sepsis, usually from meningocalcemia. The bacterial infection causes DIC, and the adrenal glands effectively bleed out and infarct. It's a catastrophic instant loss of adrenal function.
And the management is all about speed. You don't wait for a cortisol level to come back.
Never. You treat empirically. IV hydrocortisone, 100 milligrams, bolus, immediately. And you need aggressive fluid resuscitation with D5NS. You got to fix the volume, the sugar, and the sodium all at once.
Moving on to the pancreas. This is the bread and butter of the ER, but the nuance matters. We have two major hyperglycemic crises, DKA and HHS.
And while they share features, the pathophysiology is really distinct. DKA is typically a type 1 issue. There's an absolute lack of insulin. So without insulin, the cells can't use glucose, so the body switches to burning fat. The byproduct of fat metabolism is ketones, which are acidic.
So you get the triad, hyperglycemia, ketosis, and acidosis. That acidosis is what drives the small respirations, that deep, rapid breathing to blow off CO2.
HHS, on the other hand, is usually type 2. These patients have some insulin on board. It's not enough to control the blood sugar, which can go massive over 600, sometimes over 1,000, but it is enough to prevent the body from breaking down fat.
So no fat breakdown means no ketones.
And no acidosis. Exactly. So they don't get the early warning signs of pain and shortness of breath. They just get dehydrated. The blood turns into syrup-high osmolality. They present with confusion or coma purely from the dehydration.
In both cases, we treat with fluids and insulin. But there's a potassium trap here, too.
This is a major one. Insulin drives potassium into the cells. Most of these patients are total body potassium depleted, even if their initial blood levels look normal or high.
So if you start the insulin drip before checking the K+,
You drive their serum potassium into the floor. Hypokalemia leads to arrhythmias and cardiac arrest. The rule is clear. You must ensure potassium is above 3.3 before starting insulin. You often have to hang a bag of potassium before the insulin.
Now, the pancreas section of the book also covers the zebras, the neuroendocrine tumors. These are rare, but for our listeners, these are the fascinating diagnoses you don't want to miss.
These tumors arise from the endocrine cells of the pancreas and gut, and they just secrete specific hormones completely unregulated.
Let's run through the big ones quickly. First, the insulinoma.
A tumor secreting pure insulin. The patient presents with episodes of bizarre behavior, confusion, or passing out, specifically when fasting or exercising.
And we diagnose that with Whipple's triad.
Yes. 1. Symptoms of hypoglycemia. 2. Documented low blood glucose, less than 55. And 3. Immediate relief of symptoms after you give them sugar.
Then there's the gastronoma, which causes Zollinger-Ellison syndrome.
This tumor secretes gastrin, which tells the stomach to make acid. So these patients have severe refractory peptic ulcers. Ulcers in the duodenum, the jejunum places you just shouldn't see them.
What about the glucagonoma?
That one has a very visual clue. It causes a rash called necrolytic migratory erythema. It's a painful, blistering red rash that moves around the body. Combine that with new-onset diabetes and weight loss, and you have your diagnosis.
And finally, the vipoma.
The Werner-Morrison syndrome. It secretes vasoactive intestinal peptide, or VIP.
Yeah.
This drives the intestines to just dump water. The mnemonic is WDHA. Watery diarrhea, hypokalemia, achlorhydria.
And when we say diarrhea, we aren't talking about a stomach bug.
No, we are talking about pancreatic cholera. Liters and liters of tea-colored, odorless diarrhea every single day, regardless of whether they eat or not. It causes profound dehydration and electrolyte collapse.
Incredible pathology. Let's head up to the brain for our final stop. The pituitary. The master gland. It sits in a tight, bony box, the sella turcica.
And that tight space is the problem in pituitary apoplexy. This is usually an acute hemorrhage or infarction of a pre-existing pituitary adenoma.
And often the patient didn't even know they had the tumor.
Right. The tumor outgrows its blood supply or it bleeds. The swelling increases pressure in that bony box immediately.
The classic symptom is the thundercloud headache. It mimics a subarachnoid hemorrhage.
But the telltale sign is visual. The pituitary sits right under the optic chiasm, where the optic nerves cross. The swelling pushes up and compresses the chiasm,
resulting in bitemporal hemianopsia. They lose their peripheral vision on both sides.
tunnel vision, exactly. Or they might have cranial nerve palsies causing double vision. But the immediate life threat isn't the vision, it's the hormones. The pituitary controls the adrenals. If the pituitary dies, ACTH stops, and the adrenals stop making cortisol.
So you treat it as an acute adrenal crisis first.
Yes. High-dose steroids immediately. Then you call neurosurgery to go in and decompress the gland to save the vision.
Before we close, we have to touch on special populations. Schifrin dedicates a whole section to pregnancy. It's not just treating a woman who happens to be pregnant. The physiology changes completely.
It really does. The placenta is an endocrine organ itself. For example, HCG looks a lot like TSH. So in the first trimester, high HCG stimulates the thyroid. It's actually normal to have a suppressed TSH in early pregnancy.
But if they do have a thyroid storm?
It's very high stakes. Fetal mortality is significant. The drug choice matters. PTU is preferred in the first trimester because methimazole is associated with rare birth defects. But then you often switch back to methimazole for the second and third trimesters.
And regarding DKA in pregnancy, the fetus is like the canary in the coal mine.
Absolutely. The fetus is incredibly sensitive to acidosis. Maternal acidosis severely compromises oxygen delivery to the fetus. You can have fetal demise even before the mother looks that sick.
Plus, pregnant women can develop euglycemic DKA.
Right. Because the fetus is draining glucose, the mother's blood sugar might not be that high, maybe only 150 or 200, but she can still be in profound ketoacidosis. You cannot rule out DKA just because the sugar isn't 500. You have to check ketones and the pH.
That is a vital takeaway. Okay, we've toured the body from the fire in the neck to the bleeding master gland. Let's solidify this with a scenario, a challenge for the listener.
Let's do it.
Scenario. You have a patient brought in by family. She's confused, lethargic, and hypotensive. You notice a surgical scar on her abdomen, and her family mentions she has some bowel disease and takes steroids for it, but she ran out 3 days ago.
Ah, the classic setup.
Her sodium is low, 128. Her potassium is high, 5.5. You suspect adrenal crisis. You are about to administer hydrocortisone, but suddenly her blood sugar comes back at 45. She's actively seizing from hypoglycemia. What do you do first?
It's a triage question. Hypoglycemia kills fastest. You give IV dextrose, D50, immediately to stop the seizure. Then you give the hydrocortisone and the saline.
But the key here is realizing the hypoglycemia is part of the adrenal crisis.
Exactly. Cortisol is a counter-regulatory hormone. It keeps blood sugar up. Without it, you crash. So treating the sugar fixes the symptom, but the hydrocortisone fixes the cause. You need both, and you need them fast.
It all comes back to the same theme. The hormones are the operating system.
And when the OS crashes, you can't just reboot. You have to manually override the system, replace the cortisol, block the adrenaline, stop the thyroid. You have to be the external regulator until the body comes back online.
Endocrine Emergencies by Schifrin really drives home that these aren't just obscure chapters in a textbook. They are life or death puzzles waiting in the ER.
Keep your eyes open for the scars, the rashes, and the vitals that don't match the fever. The clues are always there.
Thanks for diving deep with us today. Hopefully the next time you see a check engine light, you'll know exactly what's under the hood.
Until next time.